for this province-wide rounds. Today, we're privileged to have Dr. Alex Deepu, for this as a speaker for today's round. Alex received his medical degree from St. John's Medical College in Bangalore, India, and his doctoral degree in microbiology and immunology from Georgetown University, Washington, D.C. He completed his residency training in anatomic and clinical pathology in MedStar, Georgetown University Hospital, Washington, D.C. He has completed fellowship training on histological surgical pathology, molecular genetic pathology, and cytopathology at Memorial Sloan Kettering Cancer Center in New York. He is currently a consultant pathologist at BC Cancer and a clinical assistant professor at the Department of Pathology and Laboratory Medicine at UBC. He's certified by the American Board of Pathology in anatomical pathology, clinical pathology, molecular genetic pathology, and cytopathology. He's actively involved in various professional societies in pathology. His areas of research interest include molecular testing for cytology specimens, molecular profiling of lung cancers, and development of advanced molecular techniques for clinical testing. Today, Alex is going to give us a talk on optimal histological assessment of tumor tissue for molecular testing and biomarker evaluation. Please go ahead, Alex. Thank you.
Thank you, Dr. Azar, for that very nice introduction. I'm very happy to be given the opportunity to talk to all of you today. And let me just make sure that I have the screen. If you can see the slide, just let me know.
Yes, we can.
Yeah, and, it's on full screen, right? Okay. So, as I was introduced, I do work in surgical pathology as well as molecular pathology. And as part of my work here, I try to interface between both teams, try to allow for the best use of tissue for molecular testing for our patients in the province. And as part of that goal, I have interacted with many of you on different occasions for individual cases or individual scenarios, where the question always comes up, what would be the best material to test, or what would be the best block to test, or which biomarkers need to be prioritized, and how should we process tissue to be able to give the best results for the patient without anything being depleted, with remaining material being available for additional studies and such. There is no real quick answer to that. There are guidelines given by associations, both international and national, but it comes down to our practice. And it comes down to our workflow, and it also comes down to how many people are involved in the evaluation and final testing of these samples. And as we recognize, we are a fairly big team, and we constantly work with each other. And it may be more involved than what some other systems may be, where something gets diagnosed in the pathology lab and it just gets sent over to the molecular lab or to an outside reference lab for testing. So we are unique. That does not mean that we are shortchanged because of that. I think it is a plus and a minus. It gives us a lot of opportunities to optimize our workflow, but at the same time, it also includes some very distinct challenges that we now recognize and we can all work together to solve. So that is the intent of the talk. So I will be going over some of the things that are existing in societies and literature, and then come to our own individual situation at BC Cancer and in the province. So just as a broad statement of objectives, we are going to look at the current landscape of biomarkers, various fixatives and specimen types that are available for testing, look at how there are different tissue testing requirements for biomarkers, understand the concept of tumor enrichment, which many of you do, whether you call it that term or not. We do it on a constant basis, discuss strategies for best use of tumor tissue for multiple biomarkers. And here is where it becomes very specific to our provincial experience and to our provincial situation. And finally, have some recommendations, have some ballpark numbers where all of us can be on the same page as to what do I test, what do I try to triage, when should I look for another block, and such details. So to the first part, the current landscape of biomarkers. This can never be summarized on one slide. But what I've tried to do is, on the left, I'm showing you a graph of all the genes and the hotspots that are approved by either FDA or Health Canada for treatment in certain tumor types with associated drugs. Now, that is only one subsection of biomarkers. When we talk about biomarkers, if you look at the right side, you can classify them differently. So, you can use them for diagnosis, which we all do. We can use them for prognosis, for therapy, and I bolded that because the graphic to the left is basically showing you therapeutic options. And then finally, some of these biomarkers are also tracked for progression, either to see whether the tumor is coming back, or if the tumor is already back, to see how it has changed genomically or proteinomically to allow for a differential treatment or other modalities of workflow assessment. Now, it can also be divided by the workflow. So we have immunohistochemistry that we all use. And a good example of that will be breast cancer for ER/PR HER2, gastric cancer for HER2. We use FISH for lymphomas and soft tissue tumors for diagnostic and prognostic purposes. And for molecular, all of you are aware that we use PCR and NGS-based methods. And then, of course, this is the challenge is that for many tumors now, the standard of care is a combination of methodologies. And that is one example of that will be for breast. When you have an equivocal HER2 result, you have to end up going to FISH. So you have a combination of IHC and FISH. In the case of colon, you have MMR IHCs, but you also need NGS to detect, your RAS/RAF mutations. And then, the one that we are all familiar with and we are challenged with is lung cancer, where you use almost every possible modality, where you have immunohistochemistry for immunotherapy biomarkers like PD-L1. We can use it for ALK as a biomarker, as an IHC. We use FISH when the IHCs are equivocal. And finally, now we use next generation sequencing for molecular testing, because there's more than one targetable biomarker in the lung space. Now it can be divided by approval or by, phases of testing. So some may be, ready for release and going through phase 4 clinical trials. But broadly, in the treatment space, we use things that are already approved. So either FDA, Health Canada, those would be the main ones. And then by tumor type. And what I mean by that is there are biomarkers that you can divide by exactly the tumor type, like lung, breast, colon. Whereas in the recent past, we have come across mutations or biomarkers that are pan-cancer. So one good example of that will be NTRK 1, 2, or 3 fusions, where FDA approval or Health Canada approval is not for mutation tumor type specific treatment, but if you find that mutation in any tumor type, then it is acceptable to treat with that agent if the mutation is found. Now, the final one is, by mode of therapy. So you have more target-based therapy or immunotherapy models. So that's the last one. So again, the graphic on the left is just to illustrate that the list is quite extensive. And what is bolded is, of the 3 fields that are shown, they're basically showing you only the therapeutic biomarkers approved by FDA for targeted therapy. So everything else is not in the chart. So this is certainly not an exhaustive list. There are certainly more biomarkers and more tumor types and more indications. Now, I just want to use lung cancer in this talk as a model to discuss the actual situation with biomarker evaluation with just molecular testing. So if you look to the left of the field, these are all the CAP lung cancer biomarkers assessed as standard of care. This is from last month. This is an updated document from 2021, but it has not been updated. So what this means is CAP is telling us that all of these genes have to be evaluated. So EGFR, KRAS, BRAF, ALK, ROS1, RET, the NTRK genes, MET, and HER2. All of these genes have to be evaluated for the following hotspots. That's shown in the table to the right of the gene names. So these are the hotspots or, fusions or copy number changes that need to be looked at. And then these frequencies basically tell you which are the, more common players. So if you say, what is the most common biomarker that you're likely to find in lung cancer, it would be KRAS at or close to 12%, closely followed by exon 19 deletion in EGFR. Up to a couple of years ago, there was no targeted therapy for the G12C, but now there is. So it has become a new therapeutic biomarker. Previously, the presence of a KRAS would only help you because all of these genes and hotspots are mutually exclusive. So the presence of a KRAS would indicate that the patient most likely does not carry an EGFR and could not be treated with these drugs shown on the right of the table. But now we have a drug for a G12C for KRAS and the others, G12D, G12V, they're undergoing clinical trials. The similar case holds for BRAF, and ALK, we know, has been a target for many years. But there are mutations in ALK that we need to look at that indicate resistance to the drugs that we treat with as first line. In addition to that, we have fusion genes. So those are your ROS1, RET, ALK is part of that, and NTRK. And if you actually look at the non-KRAS, non-EGFR gene list, it actually is a significant portion. So if you take 100 lung cancers and you test them, if you add up these frequencies, all of them from top to bottom, it comes to close to 40 to 45%, which means that for close to half of all lung cancers, almost close to half, can be treated with some modality of drugs. And of those, if you add up just the fusion genes, so this is 3, 1.5, 2.5, and MET exon skipping is at 4%, and your HER2, this is 10% of that 45%. So, up to 1/3 of the actual targetable list are made of fusions. Why am I making an important point to highlight that? Is because many assays, even now, only deal with DNA sequencing, and we were in that situation till 2 years ago where we were doing just a DNA test. And for the RNA, we were relying on a combination of IHC and FISH. Today, we now have RNA sequencing capability, so we are able to pick up some more of these fusions. ALK was already caught in the past with IHC and FISH, but for some of these others, they're truly new targets that we are finding in the BC population. So I think a point needs to be stated that, today we are at a stage where we are capturing almost all of the lung cancer biomarkers that are indicated by CAP as standard of care. Now, this is OncoKB. This is a resource that I use commonly. It was developed at MSK to kind of match up all of the biomarkers. So you can put in a gene name, and then you can put in a tumor type. And what it does is it will tell you, based on FDA evidence or biological evidence, you can actually change that according to your need. And it will tell you what is a level 1, which means how many of these gene mutations are matched with a level 1 notation, which means there's an FDA approved drug for that indication. So I just took all the level 1 for pan cancers to show you what the pan-cancer space is like. So for NTRK and BRAF V600E, NTRK fusions, MSI high tumors and RET fusions, you don't have to actually have it in a specific tumor for eligibility to drug. So if these mutations are found in any tumor, then they do get drug. So the point that I'm trying to make in this slide is we do have a pathway where specific cancers get specific biomarker evaluation or molecular testing to pick up certain biomarkers. Like in the lung space, everything we captured on the previous page is caught by that, and that is the reason we test. But if you think about it, the field has moved to a space where every tumor can be sequenced, because if you find any of the mutations or fusions or MSI that is on this list, then all of these can be treated with agents. So we have moved to a space where all cancers need molecular testing. However, we are not at that place yet. We are currently doing the predict pathway where all non-funded indications can be sequenced by the focus panel for these very same reasons. So we do have a pathway now, but hopefully, it will be incorporated into the provincial workflow. But the point being that all tumors are now have biomarkers that will make them eligible for therapy. So another pan-cancer biomarker that may or may not be NGS dependent is MMR or MSI. So all of you know the implication of mismatch repair protein deficiency as a germline Lynch syndrome associated biomarker. But what has evolved out of that is all of these mismatch repair gene deficient tumors also are amenable to immunotherapy. So the MMR information for a tumor now has become dual use. The first being germline implication, the second being treatment with immunotherapy from a somatic angle. So we do the MMR here as part of the germline indication, but we do have the MSI assay as a reflex for MMR equivocal cases. And newer NGS methodologies allow for MSI assessment by looking at gene loci across these repeat regions. So all of the technologies exist. Probably when CGL comes out with the next assay, one of the things that will be prioritized is the evaluation of MSI by NGS and also tumor mutational burden by NGS, because these two have become pivotal to select tumors out for immunotherapy. So just wanted to point out that when we talk about pan-cancer, it's not just the BRAF V600E or the NTRK, but also includes MSI or MMR deficiency. One of the challenges as a center to evaluate for immunotherapy is that there are various clones of PD-L1, which is the immunohistochemical stain that is used for as a companion diagnostic for selection of tumors to immunotherapy. And what we currently have here is the PharmDX22C3, and we use cutoffs that are pre-designed by the trials that showed efficacy for these agents, and they may comprise like a tumor proportion score, where it's a percentage where you only count the positive tumor cells divided by all tumor cells. But some of these other tumor types also look at some of the inflammatory cells as well. So you're getting a combined positive score. And as you can see on the right, depending on the tumor type, the cutoffs change as well. So it's a evolving space with a lot of permutations as to the immunoclone that's used for PD-L1, the drug that is associated with that is approved for treatment with the assessment of that clone, and different tumor types having different ways of assessment. That being said, like I said, the MSI or the TMB are also being used in conjunction to select out tumors for immunotherapy. Now, if we think about the different fixatives and specimen types that are available, again, using lung cancer as a model because it has the most variability, the type of material that you can receive, you can start off with an formalin fixed biopsy specimen. If it's or you can have a resection. If it has been excised out, then you can have a formalin fixed resection specimen. But more often than not, as part of staging procedures, you also get tumor material from bronchoalveolar lavage or brushings or washes. Now, these are routinely fixed in cytolite preservative, which is alcohol fixation. But Because of the relevance of biomarker IHC testing, we have seen that a lot of centers are also banking it in FFPE so that we get both alcohol fixed and formalin fixed material from these cyto procedures. The same applies, and this is part of the EBUS, procedure. But for effusions as well, when we fix them, we have an option to put it in cytolite and formalin, so that we can do all of the diagnostic work with the cytolite or alcohol fixed material, but allows us to have formalin fixed material for not just our immunohistochemical studies, but also for downstream molecular evaluation. What about other tumor types? So again, the model remains biopsy, excisions, or resections on FFPE are fair game. But if you think about high-grade serous carcinoma for BRCA testing, you have things coming from biopsies as well as from ascitic fluid, and that again can be cytolite or FFPE. One of the challenges that we have with bony mets is that they are usually decalcified and they have a high probability for failure. So what that means is if you have a decalcified sample and another one that was not fixed with decal and you have tumor in it, certainly favor sending the block which has not been treated with decal. There are other options to kind of work around this. So EDTA is one such option where you fix with the EDTA, allows you to go through like a decalcification process without using the decal reagent, and does not interfere much with the molecular testing. The other is to use embed the hard material onto a block, and then when we make a scroll, we can use minimal surface decal and get it out, so the penetration may not be as much. So these are things that have been tried and have been successful. But as a rule, specimens that have been put in decal like overnight or 24 hours certainly have a very high chance of failure when it reaches sequencing stage. Other quality issues are older blocks, like I'm not talking 2 to 3 years. This is certainly more than 10 to 15 years. In some cases, it may be inadequate fixation. So, for example, like prostatectomy specimens, the seepage into the central areas is minimal. So they may look histologically viable and well fixed, but we've seen that what we see histologically or under the microscope, even though they seem fine, when we test them, they're not the best quality. Then, of course, the one that we always run into is having scant material. We usually run into those problems mostly in the lung cancer space. For the others like colorectal, just the workflow is to test samples that are post-resection. So we, from the get-go, get bigger samples, bigger tumors, so we don't run into those problems. The final quality issue that I wanted to talk about is pigmentation in melanomas. Some of the single gene PCR assays have historically had a lot of trouble with pigmentation in melanoma samples. The newer NGS methodologies have less of that problem, but there are ways in which we can clean up the melanin pigment through different stages of cleanup. The caveat there is every time you clean up, the available amount of testable DNA or RNA becomes significantly lower. So while you're improving the quality of the specimen, the quantity certainly comes down. So if it is a minimal sample and we are trying to get the melanin out, it may be much harder. So how does that translate to us from the microscope angle is that if you have a melanoma case that is highly pigmented, obviously the burden on having more tumor to send is going to be helpful, because if it has to go through multiple cleanups, you want to be circling more areas of tumor for extraction. And finally, this is an area that is become very important over the last few years. This is the testing of cell-free tumor DNA. So the question is, if you have a patient with radiologic disease or even biopsy, but the material is insufficient, or you have long testing times or wait times, or you're looking for progression, there is there is a role, especially in the lung cancer space, to test cell-free tumor DNA to look for these targetable biomarkers. Why it is helpful is because if you do find something that is specific to lung, like an EGFR, the patient can start treatment without, even a biopsy that was confirmed to have the same mutation. The problem begins when you don't get any targetable mutations. You really don't know whether you have sampled enough cell-free tumor DNA, because it doesn't distinguish. We don't know when we extract how much normal cell-free DNA is in that sample or how much circulating tumor DNA is in the sample. So the 40% that I talked about, that's for FFPE when you know you have sent a tumor sample. When you look at cfDNA, obviously, even in a cancer patient with biopsy-proven cancer, you will never reach the 40% because not all of them will have circulating tumor DNA, and not that everything has to be captured. And these are because they get diluted in the plasma, we are talking about picking out less than 1%. So it becomes a lot harder. But this is something that is being looked at for multi-gene assessment at CGL in the future. So a lot of companies in the US are doing it. They test the cell-free DNA, and for a proportion of patients, if they're found to be positive, it actually allows for treatment and triaging and for a treatment pathway for the patient. So many people see advantages to this, and we see that too, and we do look forward to incorporating that in our workflow if there is a way forward from the testing angle. I just wanted to point out in this slide that we did talk briefly about cytology, but when we talk about samples, at least till a couple of years ago, there was a notion that cytopathology samples are not ideal for molecular testing. The fact of the matter is alcohol fixed material are better quality than formalin fixed material for any molecular evaluation, just because of the formalin cross breaks and the quality that comes out of it. But what needs to be put into consideration is when we send a block, it's not routinely just for molecular testing. They are also for IHC biomarkers, and those are validated in FFPE and work better in FFPE. And that is the reason why most centers in the world, when they have a unidirectional workflow, try to ask the pathologist to send a formalin fixed cell block, even though there may be a better cytolite fixed block available for testing. The second point that needs to be addressed is a lot of these assays, just by sheer volume, get more FFPE samples than cytolite fixed samples. So the workflow and the machines and the bioinformatics is tuned for FFPE samples. So even though cytolite or alcohol fixed samples may be qualitatively better, most of the assays are designed with FFPE in mind. And it is for that reason that, at least from the QC standpoint, that may be better. So here I have shown that there was a guidance change. So previously, there was a 2013 consensus that only certain kinds of material can be used for certain genes, but we moved way past that. It's the 2018 guideline document, and it's been in place for 6 years. Any cytology sample with adequate cellularity can be used for testing. Now, to go into the differing tumor tissue requirements based on the biomarker being performed. So I just want to point to assays, the two NGS assays that we do at CGL, and that is the focus panel, which is shown on the left, and the onco panel that's shown on the right. So if the point of this slide is to at least to have a commonality in understanding as to what is required by the assay, and based on mine and my colleagues' experience circling tumors and sending them across to the cancer genomics lab for testing, we have some feedback as to how much of tumor in terms of cell numbers may work versus what absolutely does not work. So while this has not been systematically studied, this is based off on our experience, but certainly the cutoffs are things that the Cancer Genomics Lab uses. So if we go into the focus panel, the focus panel is an amplicon-based panel, meaning it only looks for hotspots, but it looks for single gene variants, which are mutations, insertions and deletions, also in certain hotspots only, copy number variants at certain positions, fusions at certain breakpoints, and some splicing events like in MET. And what we are doing them for is for lung cancer, for melanoma, and for low-grade gliomas. Now, the OncoPanel you may be more familiar with because this is has been running at CGL for much longer, is actually a hybrid capture-based panel. So it does the full exon sequencing, and it does it for more genes. And it used to be used for lung cancer, but now is used for melanomas, colorectals, GIST, and prostate cancer, and ovarian cancers as well for BRCA testing and some gliomas. Obviously, a hybrid capture-based big panel needs more material, takes longer, and assesses more. The amplicon-based panel requires less material, takes shorter time, and evaluates less. But the point of the focus panel is that it covers all of the targetable alterations. So if you're only thinking from the treatment standpoint, the focus panel for any tumor type would be, the first test that you would do so that you can immediately get the patient on the appropriate treatment. The benefit of the OncoPanel is it also gives you mutations that are relevant to the tumor from a biologic standpoint, or even mutations that may be in trials that may be gearing up for targeted therapy. So, these will be the less common ones that are now being assessed by clinical trials across the world. So what does the amplicon-based panel do? It looks at 50-odd genes, requires at least 10% tumor content, and I will go into what that means. After extraction, it needs at least 10 nanogram of material. What is the histologic equivalent as a pathologist? I would say that if you could draw a 3 millimeter circle in a tumoral area, and you could have multiple areas with 100 tumor cells, I would say absolute minimum of 50 tumor cells in a circle, then we're talking about something that would be workable for the focus panel. For the hybrid capture-based OncoPanel, obviously, as I mentioned, the requirement is larger, so you need at least 20% tumor content, and in terms of quantity, you need at least 100 nanogram. So the histologic equivalent, based on our experiences, 2 times or 4 times that, so 200 tumor cells in the circled areas. For most IHC and FISH tests, it's just standard that we need at least 100 tumor cells for evaluation, just because that is the standard that most guidelines put out, that you need to have at least 100 for PD-L1, at least 100 for HER2 FISH. So we follow that as well. Now, I did say that I will go into the topic of tumor cellularity and tumor content. Now, when we assess a slide for adequacy for molecular testing, you have something called overall cellularity, which is all the cells in the circle that you drew. So let's say we've drawn a circle of the best area, and what we are assessing is overall cellularity. So that's the full area, tumor plus normal. We call it tumor cellularity, but it is basically overall cellularity. So what would have a high tumor cellularity? A solid tumor, like a lung solid variant of adenocarcinoma, will be back-to-back tumor glands, and there won't be any empty space in between. That is like the absolute highest tumor cellularity, where it's all tumor and no normal and just back-to-back tumor glands. The same can be in some melanoma specimens. What would be low cellularity? A cell block where you just see cells interspersed with a lot of empty space. That would be a low cellularity cell block, is a very good example of a low cellular sample. Now, if you go to the other part, which is content. So tumor content is basically a fraction. It is the percentage of tumor cells divided by the total number of cells. So one way to see that is, if you look at the picture below, you have two cores. Both have tumor in them, but the one on top has a lot of lymphoid infiltrate. The one at the bottom does not. So if you factor in that if you were to sequence this area, you're also sequencing all these lymphocytes and all of the other inflammatory cells and then getting DNA out of that. So it is actually diluting out your tumor. So the content here will be less than 50%. Here, obviously, it'll be greater because all you have are tumor cells. Now, if we make that into a grid where on the y-axis you have low tumor cellularity all the way to high tumor cellularity, and on the x-axis you have low tumor content all the way to high tumor content, you can have 4 quadrants. The first one being high content, high cellularity, and all of us can agree that those will be good to test and you send them for testing. And then, the worst one, which is low content or cellularity, they're obviously not good. Here, you don't send that block. You're looking for another optimal block to test. But the questions happen when you have either low content or low cellularity. So what do you do in these situations? When you have low tumor content, but high tumor cellularity, one example of that would be a cell block in cytology, where it is full of tumor cells, but in that circle, you don't have even 100 cells. All the 90 cells that are there are all tumor. So it's all 100% tumor, but the actual number of cells that you will get from that block are very minimal. So in this case, what you want to do is to macro dissect it, to find hotspots in that cell block where there will be higher clustering of tumor cells, so you can get enough to core to get an adequate result. So basically what you're doing is pushing this to this quadrant here. That is a low content. You're making it high content by selecting higher content areas within the whole field. What do you do when you have high content but low cellularity? And the example of that was the previous slide where you had a core with a lot of lymphoid tissue. Obviously, for comparison, I did show you another piece with a contrast where there wasn't enough lymphoid material. But what if the top piece was all you got? You have high tumor content, but you have low cellularity. So in this case, you have to attempt it, because the worst thing that can happen in cases where you have high tumor content is the sample may fail because of the low cellularity. But if it passes because of the high content, it will obviously give you a trustable result. If it does not give you a result, or if it gives you a negative result, it could be a false negative. So you can then decide to look for another block, or you can go to another sample. Now, what does this mean in terms of the coring requirements that we use at the Cancer Genomics Lab? The coring needle that we use for the circled areas have a diameter of 1 millimeter. Obviously, it's very hard to draw circles with 1 diameter. What is doable is to make the best tumoral areas at 2 to 3 millimeter diameter coring. Use 10% tumor content as a cutoff for both cellularity and content. So you don't want anything that is less than 10% on either end in terms of cellularity or content. Then we at the CGL, we end up taking more than 2 cores if there is tumor content less than 50%, because we want to increase the yield. So if you feel that the cellularity or content is less, then I would say think if the block has more than 2 areas to circle with a diameter of 2 to 3 millimeter. If that works, then it should be usable. If it's a resection specimen with a lot of tumor and we get more than 50% tumor content, we may just do 1 or 2 cores because we are confident we'll have enough to run. And if we run it, we'll get the result. Some exceptions from this rule that we use at the genomics lab is sometimes we cut scrolls. That we do to conserve tumor tissue for minimal cases, because we don't know what workup comes after. So we may save a scroll up front. And we also run scrolls as stat cases for EGFR testing when the patients are really sick. Sometimes when tumor and overall tissue is scant, like the entire area can be scooped. So when the tumor is very small, like 1 to 2 millimeters, and the tissue is also small, there's really no point in drawing a circle because, aligning that will be very difficult. So in those cases, the entire paraffin in that 2 to 3 millimeter area is scooped out. Of course, there will be nothing left in the block, but we can be confident that we have sampled everything. Sometimes it's very challenging to macro dissect cell blocks because of lack of orientation. So one good example of that are cytology cell blocks, because they're perfectly cellular. If you think there are areas in there that can be macro dissected, that's great. But when a person is trying to match that cell block and that circle to an actual block on a tissue that is not differentially shaped, it becomes very, very challenging. So in those cases as well, if you think that the overall cellularity is adequate, then I would do scrolls on it. So what can we do at the stage of cutting for H&E that allows for maximal tissue use and minimal waste? So one of the things that we've been told from many societies and also from many talks, just from experience, is avoid embedding more than two cores in one block, because the more cores you have in a block, there is a need to align all of them and to get full face of all for full histologic evaluation. And what ends up happening is you have to phase through the block just to be able to get that perfect section. If you were able to put like at least 2 cores and the additional 2 cores in another block, you're only trying to align 2 cores at one time. So, it becomes less challenging. I do understand that putting 1 core in a single block is not tenable, but certainly putting a stop to more than 2 would be good in terms of everything that we do downstream. And I think that should be strongly encouraged. Send all available blocks if the tumor is minimal. So if you think that based on what we've discussed today, that they become borderline cases, it's always advisable to send the other blocks. This is something that is already being done by a lot of our partners in the province, and we greatly appreciate that, because the transport system to get another available block and to evaluate that is certainly a deterrent. So if there is more than one, certainly send them. But if there is one good block, we've had instances where we've had 3 or 4 blocks arrive. All of them have good tumor. Since we don't get the H&Es, we end up spending an extra day trying to just cut H&Es for all 4 blocks, because the best block was not outlined in the request document. So what I would advise in these cases is to send more than 1 block, certainly, but at least note on the sheet or on your report that of the 3 blocks, this is the one I would try first, and we would do an H&E. And if that seems to be borderline, we could still have the second H&E out the next day on the second best block or the other 3 blocks. Especially in lung cancer testing, we are doing a lot of cuts up front, which means you don't want to be doing the H&E first and then everything else rephased after. You want to do one workflow. So by telling us what the best block is, we're basically running the full workflow on that block. And if they don't end up being good, then you can run the same workflow on the second block. When you send 3 or 4 blocks, it's impossible to run the entire workflow on 4 of them simultaneously. So we are pushed into a corner where we have to do an H&E first, evaluate the best one, and then run the workflow on the best block of the 4. So that's somewhere where all of us can work a little better together. But certainly if they are borderline, there is no harm in sending everything that's available. Sometimes, if, especially in the lung cancer space, if you need further assessment more than non-small cell, I would defer on the side of just calling it non-small cell, favor based on morphology. We can certainly cut the P40 and TTF1 and APSIN on site here to get better clarity. But we also understand that sometimes when we don't have enough material, it is better to err on the side of caution and get enough for molecular testing. because it's better to assume that it is an adeno and get all of the tests than to presume it may be squamous and it's not, and then that doesn't get molecular testing. For effusions and fluids, when there are abundant non-tumor cells, sometimes it is helpful, especially when we have cases on site, to look at the relative tumor content on the epithelial and mesothelial stains, so we know exactly what proportion we're looking at. So some indication of that, especially in the minimal samples, would be very helpful. Now for the last part, which will take 10 minutes, is the BC Cancer experience, some numbers, some stats as to what we do and the results we see, and some interesting cases. So for BC Cancer, we do approximately 10,000 total biomarker requests a year. And if you just use lung cancer as a model, 1,400 lung cancer biomarker requests. All of the data that I'm showing you is data averaged over a 3-month period from September to November 2021. And the overall success rate, which means every biomarker was reported for a lung case, is 88%. So of the 100 cases you send us, or we have in-house, a total number, 88% of them pass. That doesn't mean 12% of patients don't get complete results. Many of these failed cases have alternate blocks or have rebiopsy or have other specimens, and we test them successfully and we get results. So I would say it's closer to 95% in terms of a patient perspective. If you try to divide it up by IHC biomarkers, that is the PD-L1, AL, CROS1, our success rate is close to 91%. And 93% of the samples actually reach CGL. What does reaching CGL mean? We look at the slide and we say, okay, 93 of the 100 that we received have enough circulable area that we think will pass testing. So 7% we do reject here in pathology after H&E evaluation. And that is not a reflection on the assessment by the pathologist at the primary site. The pathologist at the primary site has to make an evaluation on the original H&E, but after which many tests may have been done. And when we do a recut, obviously we are not looking at the same face as that was seen by the original pathologist. So I just want to make that point very clear, is the 7% is not actually a failure of the assessment by the primary pathologist. It's actually what is existing in the block by the time it reaches here. So there's obviously going to be a differential there. And in minimal lung cancer samples, this is perfectly expected. Now, of the 93% that reach CGL, 89% complete full sequencing. So if you just look at that from a ratio standpoint, 96% of the CGL samples succeed. Again, for many of these cases, you get repeats or you get other blocks and you get results. So this is the lowest number that you will see in terms of success. In terms of patient, all the numbers will be significantly higher, and it would be only a very few patients that end up with no biomarker or inadequate biomarker results. So I think this was important to highlight because it shows the success of our strategy and the way we have been able to give oncologists the information that they need to then triage patients for treatment. This is just average cases per month at the different sites. I just thought it would be interesting. But as you can see, we get material from so many different places, but at the end, having a success rate as shown on the right is a testament to the fact that we are all harmonized in our testing strategy. Now, if we look at just what the results are like, you get a split between cytology samples. This is lung, and surgical, of course, surgical being a higher proportion, close to 60% and 40% cyto. Among the surgical samples, 60% of the 60 are biopsy specimens, and then the rest in the cytospace are FNA, pericardial pleural fluids, and such. If you think about how many, these are for advanced lung cancer cases, so all of them have documented mets by radiology or by biopsy, but what we do test, 50+% are actually the specimens from primary site, and then we test mets. This is absolute numbers, so this is like 54 cases and 51 cases over that period. that mets were tested. What does it mean in terms of our ALK positivity? So we get 1 to 2 ALK IHC 3+ positive cases a month. And for the most part, as far as we've looked at, we get confirmation by the focus panel by RNA testing almost all the time. There are some very rare fusion events that are caught by the IHC that don't get caught by the focus panel. Those are very, very rare, handful of cases. But the reason we still continue IHC is because we are able to give that within 1 to 2 day turnaround time from receipt of the block. The focus panel still takes a week. So, the patient obviously can be put on treatment with ALK inhibitor, whereas if you were to wait only for the focus panel, that's an additional 5 to 7 days. ROS1 cases that are reflex to testing are around 7 a month, and we have FISH positive cases 0 to 1. But what we have noticed is all of our ROS1 cases are also caught by NGS, so we are evaluating whether we need to continue the ROS1 IHC as part of our workflow. If you look at PD-L1 testing, close to 50% of them have greater than 50%, like 30% have 1 to 49, and like similar percent have like less than 1%, and a few of them fail. Again, absolute numbers, not percentages. Of the failed cases that you see here, 85% were surgical biopsies and 15% were cytology cell blocks. That doesn't mean that biopsies are worse than blocks. It's just we get more biopsies than blocks. So obviously the percentage will be higher. What do we see in terms of driver mutations? So we get KRAS variants at 40% in our BC cancer population, of which G12C, the one with the inhibitors, around 15%. And we see 18% of patients having EGFR mutations, of which 11% are the exon 19 deletion and 4% are the L858R. So some of our numbers do match with what was shown in CAP as a frequency, and this is the distribution of all of those hotspots. So 60% of our samples actually have an optimal load amount. What we say as optimal load amount is if there is enough material to test, we will load 100 nanogram. I did mention that we can go down up to 10 nanogram, but what we load routinely, if we have it, is 100 nanogram. But this is an important statistic. Only 60% of our samples will have that optimal load. Even for the ones that have between 10 and 100, we load whatever we have. We only have a 1% failure rate. For samples that are less than 10 nanogram, we end up having a 3% failure rate. So obviously, as you load less and less, the failure rate keeps increasing. But the 96% comes from 3% of that is actually us going above and beyond our cutoff and trying to test and actually failing. So if we had used this cutoff, we would only end up with a 1% failure rate. But the reason we still sequence less than 10 nanogram is because 7% of those have results. So, it is worth the extra trouble to even push the minimal samples. Also, at the time of testing, because we do them batched, we are not aware if that patient has another sample or not. So we try to test it. If it fails, then we come back and notify the oncologist, or when the report goes out, another block comes in. Similarly, we do the same thing for tumor content. So we say 20%, but we do test between 10 and 20% as well. So if we don't do that, our overall success rate drops to 89%. But, we are again getting 7-8% with VAFs less than 20%, between 10 and 20. So 30% of cases had no findings by this panel. 8% had like a tier 2 or a copy number alteration, which basically means not targetable. So like up to 60% of our patients have some valuable information that's coming out of the focus panel. So I do have some illustrative cases, but I think we're at close to 1 o'clock. So I want to stop here and then take questions. Thank you.
So Alex, your talk is very, very practical and very informative. Thank you. I actually learned a lot. So my comment is that the data you generated from the BC cancer experience, in my opinion, actually is publishable, and maybe it's a good idea to put it together to write it up, and because with your comments, and I think it should be a good paper. Yeah. That, I don't have specific questions. Anybody else has good questions to Alex? Yeah, it's a very nice set of data. Yeah. Anybody else has questions?
I'd also like to add that we went over a lot of data very quickly. So if anybody has any specific questions, you have my email. Please feel free to write to me about questions about individual specimens or about requirements, and I'd be happy to answer. Okay, I see a question.
He said it's not uncommon to have several blocks with a low cellularity, low tumor content. So do you want us to send all this to you for testing?
Yeah, so I mean, I think the point of the talk was to understand the 4 quadrants. So if at least in your eye, you don't feel like there is 10% tumor content and 10% tumor cellularity, which means both are low, content and cellularity are low. My point was that there is not much we can do with that block at BC Cancer. We can certainly try to test it, but I also showed that when we do them like that, the failure rate is fairly high. So my suggestion to that is, when you are encountering that situation where you don't, it may be one block or many blocks. So I'm answering the question from a patient perspective. If you think the patient doesn't have a 10% tumor cellularity and content to test, it is much better, in my experience, to let the clinician know so they can triage for another biopsy or look for other material. That is my personal opinion. But if you feel that there is even a slight chance of success and send it to us, we will certainly test it.
So his question is, if we send you multiple slides, are you able to pull the tissue together from all the blocks, and what are the chances of success?
So from a regulatory standpoint, we never combine tissue. The reason is because we accession at the molecular lab, not even by, we don't do it by patient, we don't do it by block, we do it by the way the material has arrived. So for example, you have block X. If we code that block, it would get 1 BM number. The same block, if we did a scroll afterwards, would get another BM number. So I think it's part of the safety check, because there could always be mix-ups and things like that. And the results are always dependent on us having clear idea of what kind of specimen we fed into the system. It is strongly encouraged not to combine specimens. If I need to do that, I have to go through many levels of exceptions. And that's just a bureaucratic thing, and it is not advisable. And for that reason, I would say that perhaps even in those instances, when you pool, if it's less than 10 and 10, pooling doesn't really help, because you're increasing the amount of cells. But if you're less than 10%